My slides, please. Okay, so we've heard already about coronaries, we've heard about general gender medicine issues, and now I would like to tell you something about the minimal invasive mitral valve surgery and do women have worse outcomes? First of all, as you can see, I have many interests and I hate conflict, so actually I don't have any conflict of interest, but, well, I do, because I am a woman. So, first of all, we've heard it already before, women are invisible, the patients as well, because gender bias in research has been around all along. In the basic translational and clinical studies, which were mainly conducted on the male patients, male animal models, and male-derived cell lines, because, like that, the outcomes were not disturbed by the female hormone levels. But, like this, the research findings might not be applicable to women at all, or might even result in adverse effects. So, were female patients all along lab rats? So, what we know about mitral surgery, or let's say mitral disease in females, they have a higher incidence of severe mitral regurgitation than men. They get delayed referral for surgery or treatment at all. Women don't reach the echocardiographic criteria, which is needed to get the indication for surgery, because all these demographic criteria have been established in male populations. Therefore, females also are less likely to receive surgery for mitral valve disease. They are older when they're diagnosed, they're more symptomatic, they have more advanced disease, and they have automatically higher risk, more coronaries, and more heart failure. Also, intraoperative complexity is bigger, and they get more replacements than repair, and this all results in high mortality. So, as you can see, I got here a recent meta-analysis about does sex impact the outcomes after mitral valve surgery, a systematic review from American colleagues from last year. So you could see they screened 2,000 studies, and they just found 12 which were eligible, which provided information about gender, surgery, and outcomes, which is just 0.6% of all the studies, which is very low. Nevertheless, they could include 130,000 patients throughout a span of 20 years, which is quite representative. And here, I hope you can see it. It's not so well visible like here on my screen. That's a real pity. Okay, I'm sorry for that. You can see most of the studies were retrospective. There are also some prospective or those with prospectively collected data. Most of them were either sternotomy studies or those with mitral valve treatment and concomitant procedures, or repair studies, or also including other surgery, or there was one from Seeburger, which I'm just going to show you later, about minimal invasive surgery. They also included severe ischemic mitral regurgitation patients, so one of those studies. The follow-up span is between in-hospital follow-up until 15 years, and there were 4 studies with propensity matching. So, all in all, mortality, in-hospital mortality could be found between 1.4% to 16% for males and 1.3 to 14% for females, which is actually comparable here in the El Andari papers. But on the other hand, there was another one who could show really significant in-hospital mortality, which was higher for women than in men. The other studies showed actually same outcomes, 30 days, 1 year, and 5 years. At follow-up, the Seeburger paper could show that at 10 years, there was significantly decreased survival in females. So, the morbidity, when we go on, myocardial infarction seemed to be higher in men than in females. However, stroke was higher in females, and also readmission for heart failure was higher in female patients. So, what does the meta-analysis tell us? Women are more likely to receive mitral valve replacement, which is associated with increased risk of morbidity and mortality. in-hospital mortality also seemed to be increased. These papers included all sternotomy and minimal invasive. So let's go to some papers which have only included sternotomy patients. This is from Mr. Song. So he included 25,000 patients, half of them were women, and he actually had a look at the premenopausal and postmenopausal outcomes in females. Because we know, and as we heard before already, that premenopausal women are actually protected against acute injuries like infarction, stroke, and hemorrhage. The effects of estrogen withdrawal impairs the endothelial function and increases TNF-alpha and interleukin-6 levels. So perimenopausal women have an increased ischemia reperfusion injury, and he could show it here with these two groups of female patients that between 40 and 50 years of age, females had 2.5-fold higher risk of adjusted mortality than the male counterparts, and between 50 and 60, 2-fold. Let's go to another paper with sternotomy versus minimal invasive mitral patients with propensity matching from our Italian colleagues. They had 9 centers included, a span of 10 years, and they had also 15,000 patients, but they also included mitral and aortic valve patients. However, they could show that women had a high mortality and that minimal invasive mitral and aortic surgery is safe, but obviously it did not provide a benefit for female patients concerning mortality and complications. So let's see here this minimal invasive paper, which is a unique one. We should all know that one. It's quite old, but it's still unique. It's from the Leipzig group. They had one of the largest series with 3,700 patients, which they included over 12 years. Half of them roughly were male. So they could show, of course, that females and males had totally different preoperative characteristics. That's why, of course, it's going to be a different outcome. Women were older, sicker, had more concomitant tricuspid disease. Men had higher rate of successful mitral valve repair, and therefore also probably the improved long-term survival. And women had, because of the complexity, more replacements. This is the result where they could show that at 10 years, women had worse outcomes significantly than men. So just shortly, a little intercourse about my clinic where I work. It's the HerzKlinik in Hirslanden. We've been assigned there a group of cardiologists and cardiac surgeons to implement a structural heart team center. So we have interdisciplinary discussions of every valve case, and we try to find the patient-tailored therapy for every single person. Doesn't matter man or female. And the aim is, of course, to reduce the interventional risk. We meet every week. We're surgeons, cardiologists, anesthetists, and intensivists. We are a financially independent organ, which is very important, and our decision-making is according to the guidelines and the surgical risk assessment of every single patient. We also offer some Center of Excellence heart team workshops, so if someone is interested, just call me. And here you can see 2 of our papers. This is the first one, which we have published 3 years ago. We have included 5 years of our patients operated minimal invasive and with a MitraClip. So these are all patients which have been decided to which treatment they go by our heart team. We had 185 repairs, 36 replacements, and 179 MitraClips. We could actually show that we have, of course, assigned the low-risk patients with favorable anatomy to the mitral repair, mini mitral repair group. Clip and replacement were those patients which were deemed to be high risk. Lower than expected in-hospital mortality was observed for repair and the clip patients. Also, at 4-year survival for repair and clip, we had a quite high survival. What we also could find that elderly ladies above 75 years of age and small ladies, they had an increased risk of any kind of intervention, especially for the surgery. And this is our recent paper, which we published just this year, propensity-matched outcomes of our minimal invasive mitral patients, including 300 patients for 10 years. We could also show that women were older and sicker with more complex valve pathology and more replacement, just like in the literature. But early and midterm mortality, need for re-op, and were comparable before and after propensity matching. So we believe that actually this result might be the result of our heart team decision-making approach. So the take-home message, the current findings in the literature show that women are sicker at the time of surgery, have more complex pathology of the mitral valve, therefore they get more mitral replacements, and thus have worse short and long-term outcomes. Minimal invasive surgery does not seem to be the only answer to improve the outcomes in women in mitral surgery. Our team, we believe that the heart team approach combined with the minimal invasive setting might seem to optimize the outcomes for women in mitral surgery. So the patient-tailored medicine, which we ought to practice today with the heart team decision making, is also automatically a women-tailored medicine. So what else needs to be done? Basic clinical research. We still need to understand more what is going on in women pathophysiology. We also need to enroll more female patients in clinical trials. Remember this meta-analysis which I've shown you at the beginning, 2,000 papers, but only 0.6% were eligible because there was equal distribution with the genders in it, so far too less. Then the adaptation of new criteria for surgical indication in women. Then earlier surgery for women, special chapter for female patients in the guidelines, cardiovascular screening for women. So as this invented commentary already showed last year, closing the gender gap in cardiac surgery outcomes, there's still a lot of work to be done. But here we are, and we become more visible, so let's go the way together. Thank you very much for your attention.